worked at the district attorney's office in the sensitive crimes division, and part of my role there was handling domestic violence, sexual assault cases. And so I came into this work with some knowledge of how we handle, in this community in particular, adult strangulation. And about a year into working for the Child Advocacy Center, we moved into the Sojourner Family Peace Center, and I became much more involved in the world of domestic violence as it relates to children. And the reason I'm giving this background is because this is kind of how we got to recognizing this topic, and that it's been kind of a service gap for children in our community. So we started getting a lot more forensic interview requests for children who had witnessed domestic violence and had witnessed strangulation to adults. And through that process, some of my screening questions about whether or not that adult has ever strangled anyone else was revealing information about pediatric strangulation to that child that I was interviewing, or sometimes to siblings. And what we realized was that this was happening a lot more often than we thought, and that it presented, it rarely had a medical presentation and often involved delayed reports from children. So we started to look at changing our practice, and part of that happened through the research that we'll talk about with you all today, and as part of the reason why we're doing this presentation. So as we go through the PowerPoint today, some of the things that we plan to cover, we want to talk about the scope of the problem and what that looks like in our community, and probably similar for other communities. We're going to go over some of the classifications and definitions that come up when talking about pediatric strangulation and also adult strangulation. We want everyone to understand the seriousness and lethality of this particular form of physical abuse. We're going to evaluate some of the current system response gaps that I just mentioned. And then hopefully everyone's going to walk away with some ideas of resources and screening tools so that the pediatric community can kind of come up with some more strategic and intentional plans to handle this form of child maltreatment. And with that, I am now going to hand it over to Sara.
Hello, everyone. So I'm first going to start out by talking of the problem. Sorry, I was getting some echo. So most of the research out there is based on adult strangulation, which has really facilitated them with the development of these protocols, both medically as well as a community response, and has also kind of let us know that this is a big deal and the potential severity and lethality. Just talking about DV in particular to adults, 1 in 4 women will experience a DV event. 10% of that will be a non-fatal strangulation. And if an individual experiences 1 non-fatal strangulation, it substantially increases their risk of homicide. So this was brought out several years ago by the San Diego City Attorney's Office. They were kind of prompted to do a case review due to 2 different strangulation homicides that they had experienced in their community. And interestingly, both of those 2 females were teenagers. The first was a 17-year-old. She placed a call to 911, reported being, quote, choked by her 21-year-old boyfriend. Police arrived on the scene several minutes later, and she had immediately recanted. Police did indicate that she had redness to the neck, but that it quickly faded. And then 1 week later, her boyfriend stabbed her to death. The second case was a 16-year-old pregnant female. She was found strangled to death and set on fire by her 18-year-old ex-boyfriend. So those 2 cases happened pretty close together and had a big impact on that community. So they decided to look at this problem and looked at 300 cases of DV strangulation. Half of those had no injury whatsoever. And in the 50% that did have injury, they classified it as 35% had minor injury that they weren't even photographed. And the most surprising statistic to me working in the pediatric world was that almost half of those events were witnessed by a child. So that's kind of where we step in and understand that this is a big problem and children are affected by it either by seeing it or by having it happen to them. And right now, as Lynn stated, there's really no consistent response either community-wise or medically for when this happens to kids. And a lot of that's just due to the not recognizing that this is a problem and that it is happening, the lack of screening, and also the lack of follow-up and medical care, especially timely medical care. So just talking briefly about some definitions, just so we're all using the same language. Strangulation is when there is an external compression of the neck, which can occur either manually or with the use of hands or arms, or with the use of something else like a ligature. When we talk about choking, that is when there is a foreign body in the airway causing an obstruction. Many victims will use the word as "they choked me" or "I was choked." So it's important to capture their verbiage and using that in quotations, but when we talk professionally, we want to make sure that we're all using that term strangulation. And then just an additional suffocation would then be the obstruction of the airflow into the mouth or nose, and that could be complete or partial. So partial meaning they're able to get some air in, but not enough. This next slide just demonstrates the different ways that a strangulation can occur. It can be from the front, it can be from behind, it can be using one hand, it can be using two hands, and it could be using the inside of the arm.
So now we're going to kind of go through some of the definitions that exist legally in the world of strangulation suffocation. So we have the criminal code. So we have chapter 940.235. That's our strangulation and suffocation statute. Now I think historically this has primarily been used in domestic violence cases with adults. But essentially what it says, I think this is helpful to know so that we know what we're looking for and what we're screening for, but also what elements are needed to meet these criminal statutes. But essentially this one says, whoever intentionally impedes the normal breathing or circulation of blood by applying pressure to the throat or neck or by blocking the nose or mouth of another person is guilty of a Class H felony. And that can increase if there's previous violent crime. We also have the physical abuse of a child statute, which we deal with a lot in this work. But it looks a little bit different than 4802 physical abuse, which is what is primarily guiding CPS in their determinations of how to proceed in terms of placement of children and detaining children. So 4802 talks about physical injury inflicted on a child by other than accidental means. Physical injury includes, but is not limited to, lacerations, fractured bones, burns, internal injuries, severe or frequent bruising, or great bodily harm. So I think it's important to note what the definition of great bodily harm is when we're talking about strangulation, because I think traditionally when you're seeing pediatric strangulation, and like we saw with the adult and the teenager situations that Sara had talked about, oftentimes we are not seeing physical injury on the outside of a person's body, but great bodily harm means injury which creates a substantial risk of death, so we're going to talk about that, or which causes serious permanent disfigurement or permanent or protracted loss or impairment of the functioning of any bodily member or organ. So I'm listening for those things as I'm interviewing or screening a child about whether it's they witnessed the strangulation of an adult or whether it's happening to them. And I'm going to ask questions that tell me if it's going to meet that. But even in and of itself, substantial risk of death is one of the things that we want to go over, because we're always going to be looking at whether or not it meets that criteria. So one of the things that helped me in preparing for this presentation was to talk to the people in our sensitive crimes division that handle adult strangulation. So one of the things that we had talked about was how actually well put together their screening for this is. When they go out on a domestic violence case, they're doing a lethality screening. So they're asking questions that tell them what the risk for lethality is based on certain factors. One of those factors and one of those questions is, has he or she ever tried to choke you? Interesting, because the word choke is used because that's kind of a widely accepted term for both children and adults for what we're identifying as strangulation. But in that lethality assessment, they're recognizing that adult victims of prior attempted strangulation are 7.5 times more likely to be murdered. If there's a yes to those questions, there's oftentimes follow-up interviewing based on that yes. So they're screening for it and they're following up on any positive answers. In Milwaukee, officers are trained not only to offer medical, but oftentimes victims will be required to opt out of medical care. So they would call the med unit to respond. And the victim's encouraged to obtain that evaluation. So ideally, in a perfect world, someone's explaining to them what the potential medical consequences are for not getting treated or evaluated for that strangulation. And so they can make an informed decision. And on arrival of the med unit, they would sign off if they decided not to receive any further evaluation or treatment. So some states require this type of evaluation or assessment, but in general, we recognize it as best practice for adults. So obviously, many of these things are not happening with our children on pediatric strangulation, starting from the very beginning of we don't know how to ask the questions, and we're not necessarily asking the questions at all that elicit that type of information. I'm going to turn it back over to Sara.
So this is an example of a medical protocol that was utilized for adult victims of strangulation. And I think this came about so nicely because of what Lynn just talked about, is that they have this coordinated response. And they're often being seen for these injuries or potential injuries right away, and being evaluated either by the med unit or being sent to an emergency department for further evaluation. So this is kind of, I guess, what the goal for us in the pediatric world to get to, just so that our kids have a protocol that we can follow. But it goes through asking any of the questions of symptoms they had both during the time of the incident as well as they're continuing to have, and then kind of bases what they would need either imaging wise or further workup or just watching them to see based on those symptoms and what they're still experiencing what the best method is. So this is, again, what we want to get to in the pediatric world. And then any questions, you can feel free to type them out to Sara and we will try to answer them.
There aren't any posted at this time.
All right, thank you. Looking specifically at the pediatric strangulation literature, it's pretty limited. Many of the articles are talking about suicide by hanging. Also this fad that was more popular in like the early 2000s called the choking game. It has luckily since gone away and been replaced by some of those other challenges like the Tide Pod Challenge and the Ice Cube Challenge. But this was a game that peers were playing by either a self-strangulation or a peer was strangling them to the point just before they lost consciousness. So kind of to get that euphoria. And you can see the CDC list the number of deaths per year. And it was more popular in that 2005, 2006 time frame and then has since gone down. The other strangulation that is popular in the literature is this accidental with the use of a ligature. So there are case studies based on like an amber teething necklace or something getting wrapped around a child or baby's neck. There's also hair tourniquets being wrapped around a neck. And then one of the most is the window blind cords, which hopefully we'll be seeing a decrease in that as well. But there are cases back to 1945 about blind cords being a source of strangulation. And it was such a big problem that now the Window Covering Manufacturers Association and the American National Standards Institute said that any window cord being produced as of December 15, 2018 has to be cordless or have inaccessible short cords. So just keep this in mind. Consider these as your differentials as they all would have similar presentations. But just getting that good history about what happened and your forensic interviewer can help with that as well. But really no good literature on like a physical assault for the pediatric strangulation. And then Lynn's going to discuss
one of the
case study.
Yeah, one of the things we thought might be helpful was to talk about a case that came through here. I think it identifies some of the gaps, the system gaps that we have. But what we realized was the biggest system gap, I think, is a misunderstanding about the occurrence because of a lack of screening, and also about the severity of this form of abuse. So a couple years ago now, we had seen a child that came through here. Originally, the case was called in to our Division of Milwaukee Child Protective Services for choking, routine choking by the adoptive parent, the adoptive mother. That was initially screened out. There are probably a lot of reasons why that might have happened, but ultimately something was called back in. There was a concern for neglect not long after that, a few days after that, which got screened in. So we know sometimes a history of reports can increase the likelihood of a report getting screened in. So ultimately, the reporter talked about the mother choking this child and her having marks on her neck for accusing her of having sex with the adoptive father. So the screen-in for neglect was ultimately a poor hygiene screen-in. Both police and CPS had interviewed the child at the school, I believe, and the child had reported the sexual assault incident by an adoptive father and also ongoing strangulation by mom for 3 to 4 years. So I think it's important to note that it's difficult for some of these agencies to know how to handle choking or strangulation, especially if they don't have any external injuries to know when that's occurring or whether there's an impeding danger for that child. And so part of that is just raising awareness about how serious of an issue this is. Ultimately, that case got referred to the DA's office. That child had not had a medical evaluation or a forensic interview at the time that had happened. So we're already probably limiting our ability to gather information because of the passage of time. But ultimately, the assistant DA on that case reached out to us, and that child did end up coming through for a medical evaluation and a forensic interview. So in the medical evaluation, we have some photographs of this, but they were able to see a cluster of black linear and curvilinear macules on the neck, lateral and back part of the neck. And then she, after that medical evaluation, also received a forensic interview. So I'll show you, and Sara, feel free to pipe in if you want to say anything about the injuries, but you can see right here on the back of her neck, she's got a couple of different marks that she identified as being from fingernails. And then here on the side of her neck, you can see a little curvilinear on the side of her neck there, which I believe she also identified as being from the strangulation. In the forensic interview, these are some of the things that she talked about. She talked about being scared to go home because of mom. She showed the scars. She identified them as being from choking, which won't always be the case. A lot of times children, especially really active children, they might have injuries. We might even know that they're diagnostic, but children don't always know how they got their injuries or that they even have one, especially if it's not in a place where they can see them. But she was able to connect those to prior incidents of strangulation. Said it was happening ever since she was 9. So this was a regular form of abuse in her household. She slapped me upside my head. There was blood coming down, banged her head against the wall. So we're not just talking about choking here. If we get an extended narrative from a kid, there's a lot of other things that are going on in this narrative besides just the choking. Putting her nails in made me bleed, leaving marks. Her fingernails were long. They go into the back of my neck. These are all things she reported during the interview because she thought I was fitting to die, and my brother came upstairs and said, just leave her alone. So that's an important quote because it helps us understand something about the lethality. If I ask children what they were thinking about, for example, when they're being choked, oftentimes you'll hear that they thought they were going to die, and that's something I always want to follow up on. Crying a lot, so she's describing being upset, pain, a thought about dying. We can see that at that time she was spitting up blood. So it was a very severe incident of strangulation where she actually thought she was going to die. So we learn a lot from cases like this. This was actually a situation where the mom did end up serving a prison sentence. So she went in for 1.5 years in prison and 2 years of extended supervision. Law enforcement took action upon hearing about choking. So they hear the word choking, and then they did an investigation based on that and referred the case to the DA's office. It did ultimately get screened in and handled by CPS, And our assistant district attorney's office knew, even though it was on the back end of the investigation, knew to send the kid here and give us the opportunity to provide those services of the forensic interview and the medical evaluation, which probably had a big impact on the response of the criminal justice system in the end. But what we learned about areas of improvement was that we had this initial report of potentially lethal strangulation that was screened out, a history of lethal strangulation. And Sara will talk about the impact that this can have on people physically. But that's a huge issue. And I think it's an issue of people not understanding the lethality at times. There was also a 2-week delay from the first report to when she had the medical evaluation and the interview. So if that was an acute incident, like a lot of information could have been lost in that delay, and a lot could have happened that could have compromised her ability to give us accurate information in the interview. We also know that like our documentation that might have been needed for the charging conference to make decisions about what was going to happen in the criminal justice system, but that occurred after the investigation was already referred to the district attorney's office. So had that person that received that case not known to send it back to us, we might not have gotten any of this information at all. Also, this child had to talk to a lot of different professionals before coming for the forensic interview. We have another opportunity here for questions, if there are any.
There is nothing posted at this time.
All right, so then I will turn it over again to Sara to talk about the medical significance of strangulation.
So just talking about what happens to the body during these strangulation attacks. Again, remember that that definition of strangulation is an external force on the neck. So it's going to cause either compression or obstruction of either the blood flow, the airway, or both. And going back to like the very beginning of medical or nursing training, the first thing you learn is the ABCs, airway, breathing, circulation. You need all of those things to sustain life. Without any one of those things, that's where you get the no ABC equals D or dead. So this is what makes this form of physical abuse so life-threatening and serious. There is a rare but serious effect called the carotid body reflex. So that's when there is pressure at a specific point on the neck. It's on the carotid artery nerve ganglion, which can then evoke a cardiac dysrhythmia or abnormal rhythm in the heart, and then can lead to cardiac arrest or for the heart to stop. So again, rare, but can cause death on the spot. This is a very violent and dangerous form of physical abuse, and again, I can't stress this enough, can be lethal. So looking at that first mechanism, I have a picture of the vascular anatomy of the neck. So there are two main vessels in your neck. There's the carotid artery and the jugular vein. The carotid artery is going to be supplying oxygenated blood from your heart to your brain. And then the jugular vein is going to take that deoxygenated blood from your brain back to your heart. So when you compress or obstruct that carotid artery, you're essentially cutting off any new oxygen-rich blood supply going to your brain. So when that happens, you're going to see a slowing of the pulse. And then the compression or obstruction of the jugular vein is going to block the return of blood from your brain back to your heart. This can lead to increased pressure in the veins in your neck, in your face, in your head, and increased intracranial pressure, increased pressure in your brain. So you're going to see some decreased respirations, could lead to unconsciousness, and then lack of oxygen getting to your brain. The second mechanism is going to be looking at the airway. So your airway is going all the way from your nasal openings down to your trachea where it goes into the lungs. The airway contains common things that you've heard of, like your voice box, so that's your larynx. The windpipe or your trachea is right before you enter the lungs. So this is just a nice visual of kind of that whole airway down on a child. And there's some differences between the adult airway and the child airway. The airway in a kid is a lot more susceptible to compromise. Also, the vascular system is more vulnerable to those abrupt pressure changes. So when you're putting compression on the neck, it's going to be a bigger deal, and the body is going to respond differently to that pressure change. Children typically have bigger heads and weaker neck muscles than adults, and that comes into play if a child were to be strangled to the point of unconsciousness. Once you kind of fall unconscious, you get this muscle tone relaxation. And even though the maltreater may have let go of their neck, their head could be, because it is bigger, continuing to occlude that airway or blood supply, so further injuring the child. The airway is also higher up in the neck, and that cartilage is going to be a little bit less calcified, so it's not going to break, it's more so going to bend. So you're not likely to see more of the bony breaks in children. You also have the additional potential problem of a shaking assault, which could lead to further brain injury. And we're seeing the same 50% of children will not have external signs of strangulation. So that really follows the adult literature. And you can see on the right side, there is the normal airway and then an inflamed airway. And the same amount of inflammation in a child to adult really constricts that airway. So even just the smallest amount of inflammation makes a huge difference in the child's airway. So talking about the amount of force required, again, this is all based on adult studies. I'm not sure anybody would want to sign their kid up for finding this information out. But talking about pressure, so in order to get somebody unconscious, you need 11 pounds of pressure on the carotid artery or 4.4 pounds on the jugular vein. To occlude the trachea, you're talking about 33 pounds of pressure, so a little bit more. And over 33 pounds of pressure is when we typically see that fracture, and again, that's more in adults. So this, when I read it, didn't really mean much to me. I need something to compare it to. So thinking about opening a can of soda, clicking that tab and opening it, that's 20 pounds of pressure. So substantially more than what it would take to render somebody unconscious. Anybody that's ever pulled the trigger of a handgun, that takes 6 pounds of pressure. So pretty minimal pressure we're talking about for some serious outcomes. As far as timing, again, based on adults, it takes about 5 to 10 seconds to render somebody unconscious. The earliest deaths that have been documented in adults is at 62 seconds, which is pretty quick. And then brain death occurring in 4 to 5 minutes. So it really depends on the amount of pressure, how long it's being applied, the location that it's being applied. So it could be different outcomes each time. And we have a link in the handouts. We don't have time to show this video today, but it's based on the sports science series. And it's just a really great video. It is the sports science host who has volunteered to be strangled by a professional wrestler in a very controlled setting. But you can see what happens to the body. They have him on monitors. They have medical people standing by. But you can see just how quickly things happen and what it looks like. So I would really encourage you to go check this video out. It's pretty interesting and just gives you a whole new look on this incident. So the different injuries that we see are abrasions. Sometimes people call these scrapes, but it would be the removal of the outermost layer of skin. A contusion or a bruise, which would be the result of trauma, and then the rupture of blood vessels underneath the skin. And then we also see petechiae, which are the pinpoint red or purple spots that occur because of ruptured capillaries. And while we see this in strangulation, it's not specific to that mechanism. So some of the most important things that we want to know about is what they felt at the time of the incident and what they're feeling now when we are medically seeing them. A lot of these things the child is not going to be forthcoming with. You have to ask these specific questions. So you want to know, did they lose consciousness at the time of the incident? Have they had any kind of neurological changes since? Like, have they had any seizures, headaches, dizziness? Have they noticed a difference in their face? Is one side drooping or having some weakness? You also want to ask about if they've noticed a change in the sound of their voice. Some kids will say they didn't have a voice, they lost their voice, or that it sounded really funny or hoarse. Have they had any difficulty or pain swallowing? Have they had any difficulty or pain when breathing, or any different kind of a breathing pattern? In their eyes, had they had any changes with their vision? Are they seeing spots? Some kids will report seeing twinkles, any blurry vision. What was their hearing like? Did it sound muffled? Could they hear okay? Did they have ringing in their ears? At the time of the incident, did they have any kind of urinary or stool accidents? And since then, how has their behavior been? Have they been restless or combative? Have they had any memory loss? Some of these things we can see due to the lack of oxygen to the brain, but also that severe stress reaction. And we also want to know, do they have any visible injuries, or did they at the time of the incident? And also pain is often the only presenting symptom or complaint, so that's really important to capture because we can really tie a lot about that with their statements. And the next slide is just a visual of some of the injuries that you can see. Again, we're more likely to see these injuries if we see them right away, but not every strangulation incident is going to produce injuries that are visible. So I talked a little bit about the bruising, the petechiae, any swelling of the face or the neck. Sometimes you'll see defensive injuries where they've scratched their own neck trying to pry their attacker off. So we also want to capture that. The linear marks around their neck you would see more with like a ligature or something being used. You could also see it with like a sweatshirt or pulling the back of their shirt. So different things to watch out for, but most of them are going to be concentrated to the face and the neck. And the reason we don't see a lot of external injury right now is a lot due to the timing of the disclosure and when the medical is happening. Also the thought of this is more of a compression injury versus more of the high velocity slap or hit that we're seeing with other types of physical abuse. And everything in the neck is pretty much soft tissue, so it would be harder to cause bruising to that neck, or it'd be a different force. And unfortunately, the best assessment of this injury is at autopsy, which we hope it doesn't get to, but you see more of the internal injury versus the external injury. They've often had the time to heal or fade, or may not yet be apparent. And again, there's just not that underlying bony structure for the tissue to hit and cause that external bruise. So when we find out about these, or children are referred to the Child Advocacy Center, we perform their physical exam. We want to get a complete history, including what happened during that incident, as well as any medical history that they have. We're going to go over any symptoms that they had at the time of the incident, as well as they're continuing to have now. And some of this you can work with the forensic interviewer. They may be able to get more of that information at the time of the incident during that interview, that you can kind of loop back and talk about those things. We'll do a full physical exam documenting any kind of injury with photo documentation. One of the things that I had an issue with in the San Diego case review was that they said 35% of those with injuries were so subtle they didn't even photo document. But if they're seeing injury, no matter if it's extensive or not, it's really important to document that by taking photos. And then also just referring them to any additional care if they're still having symptoms or would need some additional monitoring. I have a pretty low threshold for referring kids out just based on the significance of this kind of physical abuse. And then just make sure you're using that strangulation in your documentation. You can, again, use the child's verbiage. If they use choking, just put that in quotations, but we always want to refer to it as strangulation. And then we typically give them some return to care if they're having any of the following symptoms. The first 3 days is typically when we're monitoring them the most closely. But if any of these things were to come up after the fact, they need to be seeking care at an emergency department for further monitoring and workup. So we talked about some of the things that you can see right away. Some of the delayed consequences, the most significant is death. You can see swelling, any kind of vocal cord immobility due to that pressure on the vocal cords. It can lead to pneumonia or some pulmonary edema, which is water or fluid in the lungs. There can be some pretty significant damage to the brain, which can also lead to strokes, behavioral changes, and cognitive deficits. So we're seeing a lot of these delayed consequences. Another reason that we need to get these kids in for medical care, hopefully, and know about these incidences right away so that we can monitor them and make sure that we can hopefully have them monitored and worked up to prevent some of these things. And in your documentation, given that there is not usually or typically going to be a lot of external injury, it's really important to talk about any of those symptoms that the child tells you about, and really linking that back to why we don't see injury and why that's normal, and also just to speak to the risk of harm and potential lethality. And there's been some discussion about the use of alternative light source. Looking at the literature, there's no real great scientific evidence supporting the use of ALS in diagnosing new bruises or bruises that aren't visible to the naked eye. It does discuss using it as an adjunct when bruises are visualized and then further supporting it with the use of ALS, but not specifically finding or using it to support new bruises that are not seen by the eye. And the reason for that is it's using different wavelengths and filters, and it's looking for that fluorescence or pickup of light. And so many other things can cause that extra pickup of light, and I've just noted a couple of them there, but it's not specific to bruising.
There are no questions at this time.
Thank you, Sarah.
All right, so moving on to how we get information in forensic interviews from children about the things that we're talking about today. I think one of the things that's happened historically is that we might hear kids say something, and this happens, I think, for caregivers especially, or also people in the field, and we don't know that they're talking about strangulation. We don't hear it that way because some of the kinds of things that we say, I'm going to give some examples. He tried to choke me. That's one where you most likely will know to go down that path. This is one I hear all the time. She jacked me up. So if you don't ask follow-up questions, you might not discover that that's strangulation. I had a kid say he grabbed my shirt and put me to the fridge. Yesterday I had a little girl say he pushed mom into the bathtub and she couldn't breathe. Well, if I didn't follow up on that, I wouldn't know that that was a strangulation incident that she witnessed. She was on me and I couldn't breathe. Oftentimes you'll hear about breathing. I woke up on the floor, so that child didn't disclose anything about choking or strangulation. They were walking me through other aspects of an incident where they were getting a beating, and then they talked about waking up on the floor. And so I said, tell me everything about waking up on the floor. Well, he put his hands on my neck and I woke up on the floor. So then I learned from that. I thought she was going to kill me. What helps you know, or what made you think that she was going to kill you? Well, she was choking me. A sleeper hold. I have a lot of kids talk about like wrestling moves, and if I don't follow up on that, I wouldn't know what we were dealing with either. So it's just important to pay attention to things like that children say, and to follow up on them if you think there's any concern that you could be dealing with a strangulation incident. It won't always present as literally as we would like. And diagnosis is in the description of the event, but I think it's important to break down what kinds of information, different ages, developmentally, what kids are able to tell us. So here's an example of a 3- and a 4-year-old. The 3-year-old says, Mom throwed stuff. Mom choked Lily. She was choking her and hurting her cheeks and arms. She was shaking her. She's not going to let my sister go. She's naughty. I don't want her to do that. So she's giving some bits and details and kind of jumping around a little bit, but she's saying choking. And then she's talking about hurting her cheeks and arms. This 4-year-old says he's mad at me for no reason. Sometimes he grabs my neck and puts it on my pillow and pushes so hard on the pillow I start to cry. His hands are on my head. So I ask, where were his hands when your head was on the pillow? They were on my head doing it so hard I can not breathe. He picks up my new pillow and puts it on my face. So now we have a strangulation and likely a suffocation. She says it's just a little breathing. 6-year-old, so you can tell, as they get older, you might be able to get more details about it. She spanked me and then she choked me, and then I would say, tell me all about the choking. She first grabbed my t-shirt, went all the way down and squeezed harder, and then the child was demonstrating. So sometimes that might happen, and that's why it's so important that this is memorialized in a forensic interview, because they're demonstrating. Oftentimes when kids talk to me about choking, they're showing me at the same time. Yeah, so this one goes on. I think I asked, the child said, you better not tell your dad when you go there, but I did always. And I think I said, what helped you decide to tell? My brain helped me decide to tell. So, I mean, these are just examples of what you might hear. And obviously, when we have a teenager, a 14-year-old, for example, you're going to get a lot more of that detail, and they're going to be able to tell you a lot more about it. So it's all in just getting as much narrative as we can in the interview, and then following up on anything that can help us either establish the elements that make up any of these statutes that we talked about earlier, or to help medical providers know the severity of the strangulation, because really the diagnosis of that happening is in the child's description of the event almost always. So what kinds of questions might we ask? Children, and this is similar to adults, often won't mention strangulation unless they're specifically asked. That's why in the domestic violence lethality screening, they have a specific question that they ask about being choked, and they put it in words that are commonly used by people to explain a strangulation incident. It's the same reason we wouldn't necessarily ask a trafficking victim, are you being trafficked? Because they don't identify it that way necessarily. So what we learned was our normal physical abuse screening sounded something like, does someone ever do something that hurts your body? Or we ask about hitting, or we ask about, do you ever get marks or bruises? These are all methods of screening that are not going to elicit information about choking or strangulation. Sometimes it's described without physical pain, so sometimes it doesn't physically hurt. There's oftentimes not hitting happening surrounding it, it's just the squeezing of the neck. And oftentimes they don't have marks or bruises. So any of those kinds of questions are not necessarily going to elicit that information. One of the things I've started asking whenever a child is either disclosing witnessing a strangulation or experiencing some other type of physical abuse, if they've already reported that, I will oftentimes ask if something ever happened to their neck or to their breathing. I might even ask, does something ever happen with choking, or what do you know about choking? Because choking is a word that in and of itself isn't always indicative of physical abuse. There are other non-abuse explanations for choking, like if you swallow something and you're choking that way, like Sara had described before. Really the money question is, if they bring up anything that sounds like choking, tell me all about the choking from the time it started until they let go. I always ask what happened next after they let go as well. We might ask, tell me about your breathing. This is all establishing those elements that were in those statutes we talked about before. Were you saying something or making sounds? Sometimes they'll describe the sounds that they were making when they were being strangled. Tell me about letting go. Sometimes they'll talk about passing out, gasping for air, coughing. Those are all helpful for symptoms. Did someone have to help you? Sometimes you might have, Sara talked about defensive wounds from trying to pull a hand off of, the child trying to pull a hand off of their neck. Sometimes they might have wounds from another person's fingernails. That person was trying to pry someone's hand off of their neck. Did anything need to be cleaned up? So there I'm asking about vomiting, I'm asking about urinating, any like loss of control of bowel movements. And some of those sensory questions are helpful too. What changed in your body? What changed in your neck? What changed in your eyes? How did it feel on the inside or outside of your neck? How your face looked or felt. I'm wondering if they had any petechiae at that time. Swallowing, getting a sore throat, asking about that. What could they see? Were they dizzy? Could they see stars? A lot of times I'll hear that they could see stars or that everything looked fuzzy. And then looking at the intent and severity. So I may have mentioned this before, but there seems to be sometimes a difference between the adult strangulation and the strangulation of children, in that adult strangulation we know is oftentimes a method of exercising control over someone. I think we also see strangulation of children in that circumstance, but we see it a lot of times when a parent is losing control, not so much exercising control. They just innately have that already. But some things we might ask to know about the grown-up's intent or the severity of it was what mom said or what dad said when that was happening. Sometimes they're saying, I'm going to kill you. What did mom's face look like? What were you thinking about? Oh, I thought I was going to die, or I thought I would never see my mom again, or whatever was going on in their head helps you know how serious it was for them. What did you think would happen? And one thing that we know is that there's that strangulation of children, and I hear this whenever I'm interviewing children about it, and it's not that different from adults, but it is in some ways. I mean, this has a huge psychological impact on kids. So we're not just talking about the physical manifestation of this, but there's a huge sense of betrayal because they believe their life is in this person's hands and it can be taken at any moment. This is lethal, potentially. This is a form of physical violence that's used to kill people. And so that's a very scary thing. And for children, most often the person that's doing this is a caregiver. So they have this heightened sense of vulnerability, being helpless, feeling powerlessness. A lot of kids have PTSD and flashbacks of that moment when they thought they were going to die, or when they passed out and they didn't know if they were going to wake up again. And like we talked about, it can cause some memory loss for all kinds of reasons, because that's like an acutely stressful event for them, and that can impede with their ability to encode those memories. And it can impede our ability to retrieve them later in interviews sometimes. Some children talk about like their anxiety and sensitivity to breath and loss of breath. So if we think about situations where sometimes at school children are told like, okay, take a deep breath, try to calm down. That could be very triggering for a child who's experienced a strangulation incident and a loss of breath. So have ideas of other ways to deal with that. But it could trigger panic attacks, because that idea of having to focus so much on your breath is reminding them of those incidents of not having any breath. And also just being hypervigilant, not ever knowing when you're safe, or, this can be such an unpredictable event for children. And a lot of times that hypervigilance looks like attention issues, because, their most basic needs need to be met before they can pay attention to what's going on in the world around them. So we highly recommend cross-reporting choking and strangulation incidents or suffocation incidents between police and CPS. There are a lot of reasons for that. I think I learn a lot about this through the way that we handle sexual abuse, because again, it rarely has that medical presentation. There's often delays in reporting. There are issues with like screening and finding out about it. But it's one of the more severe forms of child abuse. It can meet multiple criminal statutes even if CPS is not involved. So it's always good to report to the police, because you could have a case that's screened out with CPS. Maybe the offender was not a caregiver, for example, but it doesn't mean that it's not criminal. It's not a criminal offense. Expert medical opinions might be helpful in determining what action can be taken by both systems, but they may not be offered or encouraged by either. So cross-reporting helps minimize the amount of children that aren't getting seen medically or for forensic interview for this type of child maltreatment. Protective planning. So if you have a case that comes first into law enforcement, we want those professionals to be aware that CPS can engage families in protective planning. So if they're made aware as well and it's cross-reported to them, even if a child doesn't have a visible injury or that, whatever the case may be, they can help and do that determining of the extent and severity, and also that protective planning can preserve the integrity of the investigation. So it can really assist law enforcement as well. Screening decisions for CPS involve an evaluation of the whole family history. So even if we are calling in strangulation and it's not getting screened in because the child doesn't have a physical visible injury, those still, you know, like we saw in that case example, the more times you call, you know, the more likely something is to get screened in a lot of times, depending on the nature of the call. So we encourage that even if you don't think something would get screened in, to be investigated by DMCPS. Joint investigations provide context. So oftentimes if you're doing a joint and cross-reported investigation, you might get information about history of domestic violence that you wouldn't have otherwise had if both agencies weren't involved. And we want to emphasize the importance of a quick response from community members because, like we said, our ability to document injuries, you know, it's compromised over time. And if we see children more quickly, it allows us to think about and ask about what symptoms occurred during or after the incident and to know whether or not more follow-up treatment is needed for this child. And we talked about those severe delayed consequences and also timely forensic interview. We don't want the forensic interview, we don't want that to be the last interview. We want that to be the interview that can be shared with everybody. So that all the information is obtained in the best possible way and the child doesn't have to keep repeating that information over and over again. And as a program, our Children's Hospital program in particular, we have been meeting and talking for quite some time now about how to do this in the best possible way and how to screen for this type of child maltreatment and then what to do with it next. So we are trying to be as adequately prepared as possible to address this severe form of child maltreatment. So we have come to the end of our presentation. I guess this is our last question slide. So let us know if there's anything more that you want to know about.
I don't have any other questions posted, so if you don't have anything more, Lynn, I'm going to proceed with my little ending announcement. Are you good to go?
Yep.
Okay, thank you very much for a wonderful presentation, Lynn and Sara. Attendees, if you have not already done so, you may now enter the text attendance code and complete your evaluation. The slide is going to come up in just a second after the resource slides. Lynn, if you can advance to the final slide, that would be great. The resources that she was showing on the screen are available in the handout, and you can get that from the handout section now. So you can text that attendance code and complete your evaluation. We'll hope you can join us next month when we have Lauren Krakowski, Sam Wagner, and Jennifer Yates as they present on the topic of sentinel injuries and child protection. Thanks so much for joining us today. Lynn, we'll leave this slide up on the screen for just a couple minutes. If you could, I know you just took it down, Lynn, if you could put that back up there just for a moment longer while people get signed out. Thanks.